Welcome back, everyone. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Hartshal. All right, so in Part 136, we covered quality programs, hospital value-based purchasing, hacks, PSI 90, and readmission penalties. Today, we're diving into Part 137 of our IPDRG Masterclass. We are decoding the engine of healthcare reimbursement, specifically focusing on pediatric and neonatal DRGs, MDC15, and how APR-DRG and MS-DRG mechanics work for high acuity care. Let's get right into it. Here is our roadmap for today. First, we'll look at the general DRG ecosystem. Second, MS-DRG architecture and severity. Third, CDI and revenue integrity. Fourth, sepsis and organ failure. Fifth, obstetrics and newborn coding. And finally, key takeaways for coders. Section 1, the DRG ecosystem, grouping clinical reality. At its core, a diagnosis-related group, or DRG, is really just a statistical system. It classifies hospital inpatient stays into groups that are expected to use a similar amount of resources. Think of it like a simple equation. Clinical similarity plus resource similarity equals one specific payment group. This is literally the bedrock of the inpatient perspective payment system. Now, to arrive at that final payment group, the logic engine needs highly precise inputs. The main driver is the principal diagnosis, obviously, but the engine also processes secondary diagnoses, procedures, and demographic details like age, sex, and discharge disposition. And as we'll see with MDC15 for our newborn patients, things like birth weight in grams and gestational age become absolutely critical inputs for grouping. It's important to understand how this system has evolved, especially in the high-acuity pediatric landscape. CMS primarily uses MS-DRGs, which differentiate cases based on complication levels. But state Medicaid programs and children's hospitals widely adopt the 3M APR-DRG, or All-Patient Refined DRG system. This adds a 4-level severity of illness and risk of mortality subclass. Why does that matter? Because APR-DRGs capture those complex, multi-system pediatric conditions that adult-centric MS-DRGs often miss. Moving on to Section 2. MS-DRG architecture and severity, under the hood. So the secret sauce in this architecture is the distinction between a CC and an MCC. A CC, meaning a complication and comorbidity, adds a moderate level of severity to a case. Think of something like malnutrition. An MCC, a major complication and comorbidity, signals high severity and massive resource use. We're talking about extreme conditions here, like neonatal sepsis or acute renal failure. Nailing that MCC totally changes the reimbursement weight. Check out this triplet structure. For a given base condition, the presence of just one MCC shifts the patient right into the highest payment tier, perfectly reflecting the intense resources used by the hospital. If there's a CC, it drops to the middle tier. And if there are neither, it sits at the lowest tier. Precision here is an absolute must. Let's look at Section 3, CDI and revenue integrity, the stakes of specificity. Look at the stark contrast here between vague and good documentation. If a provider just scribbles chest pain, you as the coder are stuck defaulting to a lower-weighted DRG. But if they specifically document acute anterior wall MI with PCI to the LAD, you are perfectly capturing the high clinical severity and the exact procedure performed. It's a night and day difference for accurate resource capture. As the source text explicitly warns, if you have a highly complex case, but the coder selects a lower DRG, say coding a simple pneumonia when it was actually multi-lobar, the hospital flat out loses legitimately earned revenue. This silent leak is known as undercoding, or a DRG downgrade, and it's a huge target for compliance audits. Specialty terminology is your best defense against these downgrades. In cardiology, for example, just writing CHF won't cut it. You need systolic versus diastolic, and that critical acute on chronic status. Miss those specific words, and you wave goodbye to that major complication classification entirely. Section 4. Sepsis and organ failure. High-stakes sequencing. Sepsis coding demands strict sequential logic. You don't just write sepsis and call it a day. Step 1, you identify the root infection cause, like E. coli. Step 2, add the severe sepsis code if shock or organ failure is present. Step 3, explicitly identify the resulting organ dysfunction, like acute kidney failure. Following this chain is non-negotiable.
You also need to watch for coupling logic. For instance, coupling acute respiratory failure with continuous mechanical ventilation for greater than 96 hours often triggers an MCC and a major jump in DRG weight. This is especially vital when validating physician documentation in the NICU, ensuring prolonged mechanical ventilation is clearly distinguished from just CPAP or high-flow nasal cannula.
Precision with kidney disease is just as critical. Take a look at this reference chart. You must strictly specify the chronic kidney disease staging based on exact eGFR ranges. So an eGFR under 15 requires a stage 5 code. And if there's an acute kidney injury layered on top of that, you have to capture that acute spike in resource use.
Let's dive right into Section 5, which is perfectly aligned with our focus for today, obstetrics and newborn coding, specialized rules.
So here is a really tricky scenario for you, pulled straight from coding clinic guidelines. How exactly do we correctly code a late preterm infant when the provider documents they were born at 37 weeks gestation? Well, the ICD-10-CM rule is incredibly strict on this. You do not assign a preterm code for infants born at 37 weeks or later, even if the provider literally wrote late preterm infant. You can't do it. Instead, you need to query the physician to see if the newborn was actually small for dates or light for dates. When auditing NICU levels of care and MDC15 logic, you've got to actively hunt for common newborn conditions. We're looking for jaundice, sleep apnea, ARDS, and weight issues like small or large for gestational age. These specific pathologies massively drive those APR-DRG severity of illness and risk of mortality mechanics we talked about earlier. And here's a highly specialized rule on the procedure side. Within the ICD-10 PCS obstetrics section, if a procedure is performed in utero, meaning on the fetus while it is still inside the mother, you must use a specific body system character. Character 0 is used exclusively to represent the products of conception. Finally, Section 6, key takeaways for coders, protecting the record. Let's recap your golden rules. 1. Always confirm provider documentation. No assumptions allowed. 2. Sequence infections properly into sepsis and then organ dysfunction. 3. Religiously capture those present on admission indicators to avoid quality penalties. And 4. Always query when ambiguous. Nailing these, especially those precise birth weight and gestational age drivers, is exactly how you defend your NICU level of care against managed care downgrades. So ask yourself, are vague clinical notes causing silent DRG downgrades and revenue leakage in your facility right now? Think on that. In Part 138, we'll be tackling advanced outpatient and ambulatory DRG integration, including APCs, APGs, and inpatient-only procedure rules. You definitely won't want to miss it. Once again, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.